Good afternoon, everyone. iTech India welcomes all the participants for today's regional distance learning seminar session. Today's topic is non-communicable diseases and mental health, prevention, screening, and management among PLHIV. And the speaker is Dr. Nivedita Dutta. Dr. Nivedita Dutta, ma'am, is presently working as a Senior Medical Officer, Clinical Research Fellow at the Center of Excellence in HIV Care at the School of Tropical Medicine, Kolkata. She is actively involved in various HIV-related research projects and has attended conferences and published articles in international journals in the relevant field. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Sweta, for the introduction. My topic of discussion today is non-communicable diseases and mental health. I will be talking about prevention, screening, and management among PLHIV.
Oh, ma'am, click on the slide and then go to the next slide.
Yeah, just wait one sec. Yeah.
Yes.
Now, the session objectives are, we will be talking about an introduction to the non-communicable diseases, hypertension screening, diagnosis, and initial management for adult PLHIV. I will be talking about diabetes mellitus screening, diagnosis, and the initial management for adult PLHIV, cardiovascular disease risk factors, screening, assessment, and initial management for adult PLHIV, mental health among PLHIV, and the common cancers and the basic screening procedures. Now, coming to non-communicable diseases among PLHIV, usually about HIV, we talk about infections and opportunistic infections, comorbidities. But nowadays, a large share of the comorbidities our PLHIV are facing is non-communicable diseases, because fortunately, over the last few decades, it has happened that our patients are surviving better with our antiretroviral drugs. And as a result, the patients are doing well and the disease burden of HIV has gone down. But on the other side, like normal populations, our patients are having the non-communicable diseases. And we need to have a comprehensive health package. Like, I will treat only the HIV part of my patient at the ART clinic is not enough now. As and when I am giving him or her HIV drugs, at the same time, I need to have a structured approach to look into the hypertension, diabetes, and hypothyroid or cancer screening, and these aspects need to be seen. NCD is caused by a combination of genetic, physiological, lifestyle, and environmental factors. Now, coming to the common NCDs or the non-communicable diseases, as I said, the cardiovascular diseases usually we see in the community are hypertension, ischemic heart diseases, stroke, rheumatic heart disease. Respiratory is asthma, COPD, occupational lung disease, cystic fibrosis, pulmonary hypertension. Endocrine is diabetes, 1, 2, or pre-diabetic stages, gestational diabetes, and renal is the chronic renal failure. Now, coming to just wait. Central nervous system NCDs, we see usually depression, anxiety, schizophrenia. The blood features are usually anemia, that is nutritional anemia is more common in our population, and the hemoglobinopathies like the thalassemias, sickle cell anemia, aplastic anemias, and the cancers like breast, cervical, lung, oral, prostate, colon and stomach cancer, and the blood cancers, leukemias and the lymphomas. And at the end, we are also having musculoskeletal, that is arthritis. These are the non-communicable diseases that basically we have to understand that our patients are not a solitary group of patients who are living in the community. As being PLHIV, they will always also have the other diseases, the other common diseases that are prevalent in the same race, the same location, and the environmental factors. Now, recommended components for prevention and management of the non-communicable disease in PLHIV. First and foremost is the health promotion, or the primordial prevention as we call it. It's basically the improving the quality of life. It's the lifestyle modification. Screening is needed. The second step is the screening for detection of the early NCDs, diagnosis of the NCDs. And the fourth step is the management of NCDs. And the regular follow-up comes at the end. Now, health promotion, counseling messages related to health behavior, like where our patients come for pill pickup every month or once in 2 months. So what are the things that we need to encourage them to do for health promotion? That is improving the quality of life. Now, like, or in other words, we call it lifestyle modifications. What we need to stress about in the counseling sessions, by it can be done by the counselors, it can be done by the physicians. We need to talk about the physical activity. A patient has to have a normal active lifestyle. He has to do some exercises, some yoga, meditation. Usually we talk about walking, morning walk or a late evening walk for 40 minutes a day. Weight control is very important. We need to calculate the BMI. Having a very low BMI or being overweight or obese is not good. The BMI should ideally be between 18.5 to 25.5. Anything above 25.5 is overweight, and anything above 30 BMI is obese. So we need to look into these factors. Again, going below 18.5, a patient is underweight. We need to give him or her high calorie diets. We need to treat with helminthics and so on. The diet also needs to be looked into. We have to counsel our patients for taking a balanced diet with whole grains, vegetables, fruits, and pulses. Diet shall be as per the local available items, nothing exotic. Restrict the salt to less than 5 grams per day. Limit use of sugar, fatty meal, dairy fat, and the fried food. Now, another important health behavior counseling is tobacco cessation, which has long-term, multiple, and short-term effects. As we know that we should discourage tobacco chewing, and we will encourage those who are non-smokers and non-tobacco chewers. Avoidance of alcohol is also important. We have to use of alcohol should be avoided as far as possible. And if a patient is a habitual drinker, the alcohol content should be like they should be having a cutoff for daily consumption. Now, counseling messages related to adherence. This is very important as we all know, pertaining to the antiretroviral clinics. We always keep telling about how many doses you have missed, how many medications have you missed in the last 1 month or last 2 months. We have to tell our patients, we have to explain to them that what is the importance of adherence to medicines for NCDs along with the ART. Like we have to take our ART with the same adherence as we are taking our medicines for NCDs. And we also have to see that additional medications do not hamper our ARVs. At the same time, we have to tell them that why do we keep on talking about adherence? What is the importance of adherence, both in the terms of diseases like hypertension, diabetes, at the same time with ARVs? So a patient needs to have it's not like a patient will be only aware of the need for adherence for his antiretrovirals. At the same time, he needs to have an understanding of the need to continue the antihypertensives, oral hypoglycemic drugs, and thyroid medication supplements. These also need to be understood by the patients. Now, hypertension, I will be talking about a basic screening, diagnosis, and the initial management for adult PLHIV. All PLHIV above the age of 18 years should undergo screening by healthcare providers through blood pressure monitoring. Here we are talking about screening for only above 18, but for CLHIV or the children also, monitoring is essential. It is not that children should not be monitored, because we have diseases like pheochromocytoma, Cushing syndrome, congenital adrenal hyperplasia, hypo or hyperthyroidism, aortic coarctation. There are some specific but atypical clinical conditions where we may need to monitor the blood pressure in children also. Now, ideally, BP should be measured in all PLHIV at initiation of ART and every 6 months, as and when the need is felt by the physicians. Now, diagnosis of hypertension in adult PLHIV, physician it should be validated by a physician. The nursing staff can measure the blood pressure, and it should be now hypertension should not be classified by only one recording. This is very important. Often we do the mistake of labeling a patient as hypertensive by only measuring one recording for hypertension. Ideally, at least 2 measurements or 2 readings should be obtained on 2 occasions to estimate the individual's level of BP. Often we have this white coat hypertension when a patient is coming to a clinic, he or she is meeting the doctor or the nursing staff, and they are stressed out, they are tired, and they have a high BP. So out of office or out of clinic measurement and self-monitoring of BP should be recommended. And when we have a single high reading, we should always go for 2 or 3 readings within 4 weeks, so that we can understand whether the patient is having hypertension or not. Now, there are certain stages of hypertension. Like if we find that the BP is more than 180 by 110, in those cases, we term or label that hypertension as hypertensive urgency or hypertensive emergencies. There's a slight difference between hypertensive urgency and hypertensive emergency. When we are having a BP of more than 180 systolic with 110 diastolic and no other target damage has been picked up, only those cases are called urgencies. But when we have established any cardiac or cerebral or renal damage or retinopathy, in those cases, we will term them as hypertensive emergencies. Now, hypertension should be diagnosed. Here it is 140 by 90, but usually we follow this is according to the Ministry of Health of India, but usually we follow the European or the American Cardiology Society, where hypertension is anything above 120 by 80 nowadays. They are very strict about the measurements, and what we do is usually when we are having 120 to 130, the systolic blood pressure, that we call as elevated. Like a person is having a blood pressure, a systolic with between 120 and less than 130, and a diastolic of 80, that is called elevated. And when a patient is having a systolic of 130 by 80, at that point we start naming them as stage 1. Now, the diagnosis of hypertension, along with that, these two usually come together. We need to assess for any type of diabetes, and along with hypertension, if we have diabetes, we have to look for diabetic nephropathy. As we all know, with diabetic nephropathy, our tubules are excreting lots of protein, and there's proteinuria, and then there's a loss of protein from our tubules. And as a result, this leads to high morbidity and mortality. Now, desirable is a BP of 160 by 100. For this is a slide I would not like to explain like this, because dyslipidemia is a risk which has to be measured in all patients nowadays. And any adult, dyslipidemia needs to be screened, because we are having a lifestyle where we are more prone to fatty food, where we are more prone to having sedentary lifestyles, less of exercises. So, and above in a certain age of 40, we need to screen for dyslipidemia in all patients. So lipid profile has to be done, not just because a patient is having hypertension. Dyslipidemia has to be seen isolated and treated. Now, serum creatinine is another factor. After a certain age, an adult, we have to screen for creatinine regularly. So, and once the creatinine screening has been done, if it is at all high, then the next test will be sodium and potassium and assessment of the renal function. Now, if a patient is having a really high BP, like the one on the desirable line, then only we will go for an ECG and echocardiography to ideally suspect or detect left ventricular hypertrophy. So just a point of difference is that lipid profile has to be done for all adults. Serum creatinine also has to be done for all adults, and this will be followed by sodium and potassium and renal functions if it is elevated. And ECG and echo is for really those stage 2 hypertensive patients who have suspected end organ damages and for LVH. Now, the target control, this age, I think this is the slide which is according to the Ministry of Health, but according to the American and the European guidelines, and also the recent Indian guidelines, ideally a BP should be every person should be having a BP of 120 by 80. If the systolic BP is between 120 and 130, then we call it a elevated BP. Now, when the systolic blood pressure it goes above 130 and the diastolic blood pressure goes, when the systolic blood pressure is above when the systolic blood pressure is above 130 but less than 140, and the diastolic blood pressure is above 80 but less than 90, we call it the stage 1 hypertension. And then when the systolic blood pressure is above 140 and the diastolic blood pressure is equal to or above 90, we call it stage 2 hypertension. And as I said, all these readings should be at least 2 readings obtained on 2 occasions. Now, so as I said, we have only 4 categories of hypertension nowadays. One is elevated, one is stage 1, stage 2, and then comes the hypertensive emergencies or the urgencies. Now, lifestyle modification is limiting the salt to 5 grams per day, low fat diet, regular exercise, and maintaining a weight between 18.5 to 22.9, or it may be 25.5, and smoking cessation, that is a normal BMI. Now, the antihypertensives I will be talking about, we have these are the basic first line group of drugs, that is ACE inhibitors, the angiotensin receptor blocker, the calcium channel blocker, the thiazide diuretics, and the beta blockers. These are the first line group of drugs. Now, angiotensin converting enzyme, we know that it is enalapril, and ARBs like losartan. For ACE inhibitors and ARBs, we should be cautious that these lead to high levels of blood potassium or serum potassium. So these should be used with caution in patients with CKD. Now, amlodipine, cilindipine, calcium channel blockers are also good drugs, but they often cause pedal edemas. And these calcium channel blockers are a very good drug for first-line patients. And the thiazide diuretics, they act wonderfully, especially when patients are having a sustained high diastolic pressure. And then we have the beta blockers, but beta blockers are not to be used as the initial treatment. They should be reserved for patients who are like not having a good outcome with the first 4 group of drugs. Beta blockers, we need to remember that ideally beta blockers should be given for patients who are having some amount of reduced ejection fraction, some amount of cardiac heart failure. Beta blockers ideally should be reserved for all those patients. These are atenolol, carvedilol, bisoprolol, metoprolol. And now beta blockers, we need to remember is abrupt cessation of beta blockers should be avoided. And bisoprolol, metoprolol are preferred in hypertension with reduced ejection fractions. And bisoprolol is a good drug when you have bronchospastic airway disease along with hypertension. Now, it is important to screen for and manage the cardiovascular risk factors in adults with hypertension, like, as I said, smoking, diabetes, dyslipidemia, excessive weight, low fitness, unhealthy diet, psychosocial stress, and sleep apnea. Basic testing for primary hypertension includes fasting blood glucose, complete blood cell count, lipid, basic metabolic panel, thyroid stimulating hormone immunoanalysis, ECG with echo, and urinary albumin to creatinine ratio. Now, this is a grade. This is a grade by the Ministry of Health. but according to European and American, which is being followed now, it's basically a grade 1 hypertension is something in between 130 to 140 by less than 90. Grade 2 is basically any blood pressure above 140 and above 90. Sorry, 140 by 90. And then grade 3 is the hypertensive emergencies and the urgencies, that is 180 by 110. Now, grade 1 and grade 2 are usually managed by the first line drugs. As I said, the 5 group of first line drugs. And for the grade 3, that is the hypertensive emergencies and the urgencies, we preferably need to admit the patients and introduce the drugs one by one under very close supervision. The dose of drugs can be increased or a new drug added at approximately 2 to 4 week interval. Frequency can be faster or slower depending on the clinical circumstances and the judgment of the physician. Ideally, introducing multiple groups of drugs is better than giving a high dose of only one type of drug. As logically, we can explain it like multiple types of mechanism of action help to reduce the blood pressure at multiple sites. And when we are increasing only a single drug and we are increasing the dose day by day because of poor outcome, that affects the hypertension that is acting at only one point. So it's better to use multiple group of drugs so that they act at multiple sites. Now, SE inhibitors are the preferred first line for initial therapy, but as I said, SE inhibitors and ARBs need to be used with caution in the CKD patients, as we have this increased potassium with SE inhibitors. So, and CKD patients also, we know that they have hyperkalemia. So to avoid hyperkalemia, that should be taken into with caution. Screening for secondary causes of hypertension is also very essential for uncontrolled hypertension in adults, where we have seen that the stage 3 types where the drug resistance is occurring, we are giving too many drugs. In those cases, we also have to see the with CKD, whether the patients are having CKD or any coronary artery disease, they are having left ventricular hypertrophy or not. We have to look into the retinopathy, cerebral vascular disease, all these issues need to be seen. So whenever we are having a hypertension where we are, it's not stage 1 anymore, it's a stage 2 or it's the emergencies or urgencies, we have to look into CKD, renovascular diseases, primary aldosteronism, obstructive sleep apnea. These are very important. And some drugs also induce hypertension like NSAIDs, steroids, androgens, decongestants, caffeine, and the monoamine oxidase inhibitors. And there is also something called alcohol-induced hypertension. So physicians need to be alert on these issues while treating our hypertensive patients. As I said, SE inhibitors and thiazide diuretics do not have any interaction with ARVs. Usually they do not have any interaction, but there are potential interactions between calcium channel blockers and beta blockers with ARVs. Now, as we all know, the protease inhibitors we take always has ritonavir with it. Ritonavir is a cytochrome P450 inducer, so it has the tendency to decrease the blood level of all drugs because it's metabolizing faster. And the NNRTIs, it inhibits the cytochrome P450, so the drugs are metabolized slower. So the presence of ritonavir in any ARV combination always tends to increase the dose of other drugs. Very plain and simple. So if my patient is having a PI, the other dose of the other drugs which are being metabolized by the hepatic, same cytochrome P450, may be needed in a lower dose. NNRTIs are not in use nowadays, but NNRTIs like efavirenz, they had this the reverse effect of decreasing the blood level of drugs. Now, caution should be exercised when administering beta blockers and PIs due to the risk of QT prolongation, as we know that atazanavir has the propensity to cause QT prolongation. So when we are administering beta blockers, which usually causes a decrease in the heart rate by QT prolongation, we should be cautious with the heart rate. Now, the care provisions and referral screening, diagnosis and treatment of uncomplicated hypertension can be provided by a trained medical officer. Grade 3 hypertension and failure to achieve, these ideally should be, initial stage 1 and stage 2 can be with us, but the stage 3, the emergencies and urgencies should always be dealt by an expert physician. Now, two or three things which I would like to also say, that the BP goal with a CKD patient and a diabetic patient should always be like it should be kept below 130/80. In contradiction to other, like for other patients, we always think that 140 may be a tolerable BP. No, but whenever we find that 130 has been reached at the systolic level, we should start treatment with our diabetic patients and also with our CKD patients. Now, coming to the diabetes mellitus screening, diagnosis and initial management for adult PLHIV. All PLHIV should undergo screening through random blood glucose test at the time of registration. Ideally, a random blood glucose test should be replaced by a fasting blood glucose, because a random blood glucose test does not help us to estimate whether the patient is having high blood sugar or hyperglycemia or not. So preferably a fasting blood sugar. And if the fasting blood sugar is high, then we will repeat it again. We will do a PP sugar, that is the postprandial sugar. We will also do a HbA1c. And we have to identify whether my patient is having high or borderline hyperglycemia. Now, usually the symptoms which are to be picked up at the clinics are polyuria, polydipsia, weight loss despite polyphagia, tiredness, weakness, generalized pruritus, recurrent urogenital infections. This is very common. And urogenital infections, a person is having recurrent UTI, but the basic reason is because he or she is having hyperglycemia. Delayed healing of the wounds. This is also very common with hyperglycemia. So the diagnostic criteria for diabetes is a fasting blood sugar of more than 126. I will not talk about random because it's not very handy to diagnose. 2-hour postprandial with sugar 75 grams of glucose is very useful. It's a part of the oral glucose tolerance test, and it's a very sensitive test. It's a very good test and sensitive test. Whenever we are in doubt whether a patient is having diabetes or not, we prefer to go for a 75-gram glucose test. And the glycated hemoglobin, that is around more than equal to 6.5 HbA1c levels. HbA1c levels, basically, they are an estimate that gives us the history, how the patient was doing in the last 3 months. Basically, if we remember that the lifespan of a hemoglobin molecule is around 120 days. So when we do the hemoglobin, glycated hemoglobin, that is, it shows the history that if sometimes we want to, I have an elevated fasting sugar for my patient, and I want to know for how long is this patient having this elevated high blood sugar. So an HbA1c test helps me determine it, because it gives me the record of the past 3 to 4 months of hyperglycemia. So if it is elevated, I know my patient is having a hyperglycemia, not for this one setting, but for the last 3 to 4 months. Now, coming to the blood glucose, FBS and 2-hour PPBS, at least once a month or more often if values are not in the ideal target range. Ideally, we should be starting a patient on oral hypoglycemics, and a regular follow-up should be done 2 months or a 3 months interval. HbA1c preferably to be done once in a year. Clinical examination should be done at every visit. He may be having some ulcers, some wounds that are not healing. And retinopathy, nephropathy, neuropathy, peripheral vascular disease, and coronary artery disease, these are to be screened for at least in 1 year or preferably in 6 months. All diabetic patients, poorly controlled diabetes, should be sent for retinopathy or eye checkup and a nephropathy screening. Optimizing the weight, waist circumference, blood pressure, and the lipids. About neuropathy, I would like to say something that often our patients are complaining of burning sensation under the foot, that is at the soles. This is a very common neuropathy complication of diabetes. as we know that the very fine blood vessels, which when they are having a high content of glucose, they go into spasm, they are obstructed, and the nerves get some amount of anoxic damage. And that is the reason for neuropathy in the acral regions. Optimizing the waist management, circumference, blood pressure, lipids is important. Routine examination of the foot has to be done for every diabetic patients, whether they are having any foot ulcers that are non-healing ulcers, and the care of the foot has to be taken, advised. Also, we encourage that patients always wear very good shoes or sneakers when we are talking, when we are counseling our diabetic patients to go for morning or evening walks, because we do not want them to have some small cuts and injuries in their foot or the toes, and which will be difficult to heal. So always advise our diabetic patients to go for morning or evening walk or exercises with very good shoes covering the whole foot. Discourage the use of tobacco and excess use of alcohol in diabetics. Now, additional information investigations is lipid profile, serum creatinine, urine analysis for proteinuria. As we all know, that diabetes usually causes nephropathy, and the protein is lost along with the urine. And this is the earliest sign of diabetic nephropathy, which needs to be treated alarmingly as soon as possible. For patients with pre-diabetes, abnormal results but do not meet criteria above for diabetes, we have to monitor every 6 months and encourage the lifestyle modification, which is very important. Lifestyle modification, as mentioned under health promotion, is recommended. If target blood glucose is not achieved after lifestyle modification, then we give metformin for type 2 diabetes. For type 1 diabetes, as we know, that is the inherent absence of insulin that occurs in kids and detected in adolescents. Type 1 is totally dependent on insulin. So there is no role of oral hypoglycemic in that. All oral hypoglycemic I will be talking about is for type 2 diabetes. So what we do, we start with metformin. We then give sulfonylureas. And now with metformin, we have to titrate the dose of metformin. We start with 500, then we give 1000. And then we also give the sulfonylureas like the glimepiride, glipizide. And we also have the thiazolidine diones like the rosiglitazone, pioglitazone. Now, sulfonylureas may be given to patients who have contraindications to metformin. It can also be given as an add-on, not only contraindication. Like with patients with diabetes, mellitus are at increasing risk of developing TB, because diabetes, like HIV, it drops our immunity, and therefore it is patients are becoming more prone to all types of infections. Now, while using metformin, we should be cautious about few things, like metformin cannot be given in patients having renal insufficiency, less than 30 ml per minute GFR. For patients having less than 30 ml per minute GFR, metformin is contraindicated. Or patients having less than 60, metformin should be given in a low dose. For liver disease also, we have to see that metformin is not used. And active infection, including TB, here I do not understand here this line, because metformin, as has been seen in various studies, it limits the intracellular growth of Mycobacterium TB and reduces the drug in resistance of the TB drugs. So metformin, basically it acts by one adenosine monophosphate AMP pathway, and metformin limits the intracellular growth of Mycobacterium TB. So metformin, I think it helps in the treatment of TB. It helps reducing the drug resistance in TB, and also reduces the bacterial burden. Now, with congestive cardiac failure, due to the risk of lactic acidosis induced by metformin, it should be used with caution. Now, metformin, a dose of 1000 can be given with dolutegravir, as we all know now by this time, and we should not exceed a dose of 1000 milligram of metformin when we are co-administering dolutegravir. What happens is, basically metformin The dolutegravir increases the metformin plasma exposure. The area under the curve of metformin is increased when we give dolutegravir along with that, because DTG inhibits a cation transporter 2, that is what called CT2. This CT2 metabolizes metformin. So what happens with dolutegravir is the metformin blood level goes sharply high. So to avoid disasters with metformin application, we need to control the dose so that there is not, we do not have a very high area under the curve. So we have to remember that dolutegravir inhibits the cation transporter 2, which metabolizes metformin. The metabolism of metformin is reduced or slowed down. As a result, the availability of plasma metformin is high. So to decrease the catastrophes with high metformin and hypoglycemia, we are reducing the dose of metformin. Monitoring the renal function and the blood glucose is recommended when metformin and DTG are co-administered. I said just now that if we are having a compromised renal function, we cannot give metformin. NNRTI and PIs may cause increase or decrease in levels of sulfonylureas. As I said, PIs have ritonavir. Ritonavir is a cytochrome P450 inhibitor. And as a result, what happens is all the drugs which are metabolized by the same hepatic pathway, their blood level goes up. And in RTIs, they act opposite. They are the enzyme inducers. And as a result, most of the drugs which are metabolized by the hepatic pathway, their blood level goes down. Now, coming to the screening, diagnosis, and the initial management of diabetes mellitus, we know that we have basic 3 groups of drugs. We have to give the oral hypoglycemic agents. Continuation of treatment has to be done by a trained medical officer, or we can refer the patients to the diabetic clinic or a medicine OPD if we have one. Patients should be always taught about the signs of hypoglycemia when we are giving treatment for diabetes. And the foot ulcers, vision impairment, these need to be looked into. Now, what we give is usually metformin we give, sulfonylureas we give, and the thiazolidinediones are given. Now, I will be talking about the cardiovascular disease risk factors, the screening, assessment, and initial management. Basically, hypertension, diabetes mellitus, dyslipidemia, obesity, that is a BMI of more than 30, physical inactivity, tobacco use, excessive alcohol consumption, unhealthy diet and nutrition, family history of cardiovascular disease. These are all the risk factors for cardiovascular diseases. Assessment shall be done at time of registration in HIV care or ART initiation. If a person is found to have some positive outcomes for cardiovascular tests, we need to refer these patients to a cardiovascular OPD. Preferably a cardiology OPD can handle these cases. But we have to screen our patients. What we need to remember at the ART clinics is we can screen our patients. Any patient having a history of stroke, that is a cerebral stroke, diabetes, or hypertension. These people should always be asked for chest pain, breathlessness on exertion, and breathlessness at rest, numbness or weakness of the limbs, loss of weight, increased thirst, polyuria, puffiness of the face, swelling of the feet, passing blood in the urine. We will ask about the past or the present medication and treatment, use of tobacco, alcohol, sedentary or active lifestyle, premature heart disease, any childhood heart disease, or any history of stroke in the first degree relatives. Now, for assessment, we can always do a simple BMI. We can measure the blood pressure. Signs and symptoms of diabetes mellitus can be asked. And what will be the other signs that a physician will be looking into? Pitting edema, heart murmurs, basal crepitations in the lungs, and tenderness in the abdomen. Now, so what I said was few symptoms, like a patient is having chest pain, sense of breathlessness on effort, some without effort, numbness of the limbs, loss of weight, increased thirst, polyuria, facial puffiness, swelling of the feet, passing blood in the urine, having a pitting edema, heart murmurs, and basal crepitations. Always refer these patients to the cardiology OPD or the medicine OPD, whichever is available at the nearest. Health promotion and lifestyle modification will go side by side. And all patients having dyslipidemia along with established cardiovascular diseases need to be prescribed statins. Usually we give atorvastatin. A 10 milligram dose is enough for patients having a PI because, as I said, ritonavir increases the dose, but we can also go for a dose of 40, up to 40 usually we give for patients who are having other risk factors. Now, coming to the mental health among PLHIV, this is something we often overlook. PLHIV are prone to psychological ailments due to HIV per se, as well as opinions and experiences regarding HIV in their surroundings. They face multiple types of psychological issues like depression, anxiety, internalized stigma. Any issue can significantly hamper adherence and their mental well-being. Depression is 2 or 3 times more prevalent in PLHIV than in the general population. Because a person who comes to know that I am having HIV and he is having depression, which is his own, at the same time he's anxious about his future life, his future well-being, and the stigma, the fear of others knowing it, how others will treat him. All these issues are they all combine to give rise to depression and the mental disorders. All PLHIV should receive basic screening for depression before initiating ART and thereafter every 6 months. This is very important. When I ask my patient, are you taking your drugs? At the same time, we should ask, are you feeling down, depressed, or hopeless? Have you felt so? One sec. During the past 2 weeks, have you often been bothered by little interest or pleasure in doing things, like what we call as anhedonia, having little interest in every pleasurable activity around? Through thorough screening for depression using the PHQ-9 screening tool and scoring pattern, I will discuss in the next slide. This patient health questionnaire, these set of questions are very important. These can be learned by our counselors, our nursing staff, and our physicians. They are very handy, and they are basic questions that help us to understand whether a patient is having depressed, how often they are having it, and does this depression need medication? Like I will be asking 9 questions, that is the patient health related questions, and these 9 questions, if the person is having for several days, more than half the days, or nearly every day. So this scoring it's a very handy chart. We can always look at that and we can ask our patients whether they are having little interest or pleasure in doing things, they are feeling down, depressed, or hopeless, having trouble falling asleep or staying asleep, or they are sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself or that you are a failure or have let yourself or your family down, trouble concentrating on things such as reading the newspaper or watching television, usually trouble in those things which are usually that kept you engaged previously. Moving or speaking so slowly that other people could have noticed, or the opposite, being so fidgety or restless that you have been moving around a lot more than usual. Thoughts that you would be better off dead or hurting yourself in some way, that is the nihilistic thoughts, or suicidal attempts, the thoughts that I might why not attempt a suicide? So these are the set of things that we need to look into our patients. Often we find that patients are depressed or hopeless. They are having sleep disorders. They are tired. They are either they are eating or having overweight, excessive weight, or they are having very poor appetite. So these are the issues. And if we are having a high score, then we will always refer the patient. It is not that depression will be cured on itself. It hardly cures on itself. We have wonderful sets of drugs nowadays. It's best to refer a patient to a psychiatrist. Now, the psychosocial support, self-management skills, and reducing stress. Some supportive counseling can be done for the depression patients. We can explain the patient what is depression and how it can be managed. And we will tell him that hopelessness, worthlessness, negative emotions are part of depression, because he or she might be feeling that it's something I do not identify. But if we as physicians can identify the thing that is it's a part of a disease, it is treatable, then it's easier to counsel a patient. Inform on the course of counseling and treatment. Supportive family members can be identified and involve them as appropriate. Involve the peers and the community support groups. Peers do a wonderful, remarkable thing, because they are also going through the same trauma or the same type of mental and physical anxieties that our PLHIV is having. So involving the peer is a very healthy habit. Self-management is first I will ask my patient to continue the ART, then do the pleasurable and interesting things, encourage them, get regular and sufficient sleep. If needed, we will add the anti-anxiety medications, physical activities to be increased. The more the physical activity, the lesser we know that we have these good hormones, as we call them, the endorphins, and the physical activities lead to a lot of secretion of the good hormones are like endorphins, and that gives us a very good sleep. We contact the healthcare facility. We should always tell them that healthcare facilities should be contacted SOS whenever you feel you have those nihilistic ideas that you want to harm yourself. Identify and reduce the stress points, identify the stress issues, talk to their families, partner violence, finances, stigma, and we can always teach them how to meditate and the relaxation techniques which will help them to reduce stress. Medical management of depression. Depression can be managed by a combination of medical and psychological interventions. As I said, antidepressant treatments have to be given. There are mainly two or three groups of drugs, like there are the tricyclic antidepressants and the SSRI, or the serotonin selective serotonin reuptake inhibitors. Basically, we give SSRIs first: escitalopram, fluoxetine, sertraline. These are the three groups of three drugs amongst the SSRIs which are the most used. Escitalopram in a dose of 10 milligram per day, fluoxetine starting dose of 20 milligram per day, sertraline a starting dose of 50 milligram per day. But usually we have dry mouth, constipation, drowsiness, nausea, vomiting, sexual problems, and sleep difficulties with SSRI. And there is a caution with the use of SSRI in narrow angle glaucoma, pregnancy, and we always avoid SSRIs with the MAO inhibitors because both cause a rise in serotonin levels. Now, coming to the tricyclic antidepressants, amitriptyline, trimipramine, and imipramine may be given. Amitriptyline at a starting dose of 50 and then 100 at bedtime. Caution similar with SSRI, that is the narrow angle glaucoma. Tricyclics can result in arrhythmias, blurring of vision, dry mouth, constipation, and we should we should be having caution with these. Atypical antidepressants like mirtazapine are also used, 15 to 30 milligram per day. Avoid with the MAO inhibitors. And with mirtazapine, we have agranulocytosis, increased cholesterol levels, and increase in liver enzymes, which need to be looked after. Now, mental health disorders during childhood and adolescence are also very common. Prevalence is quite high among the children between 13 to 17 years of age. So mental health should not be ignored in children. And then coming to the warning signs, persistent sadness, withdrawal from avoiding social interactions, hurting oneself, talking about death or suicide, outbursts or extreme irritability, out of control behavior, drastic changes in mood, behavior, or personality, changes in eating habits, loss of weight, difficulty sleeping, frequent headaches or stomach aches, difficulty concentrating, changes in academic performance, avoiding or missing school. These are the conditions in children and adolescents which are alarming signs. We have to pay attention to these, otherwise we will miss our patients. So I'll end my mental health topic with these series of things like with the children and adolescent, the warning signs. Now, next topic is just a brief screening about the common cancers among PLHIV. Prevention is our first motto. We know that we have to screen for tobacco use. We will discourage tobacco usage. And then something we need to remember is general guidelines for the PLHIV on treatment of a cancer. Often patients receiving radiotherapy or chemotherapy are referred to the ART center that should we continue ART with radiotherapy or chemotherapy. The only thing is chemo or radiotherapy often causes the WBC count to go down. So we have to look into the issue, the drugs like the Zidovidin had a serious side effect of reducing having a leukopenia. So this leukopenia needs to be addressed, and since Zidovidin is almost being phased out now, we do not have to think about it anymore. But drug interactions, HIV drug interaction, Liverpool, we can always go to the website. We can check the number of anti chemo drugs and any surgical intervention drugs, and we can advise our patients about the drug interactions. But under no circumstances should we stop our ART. Detection of cancers, the early warning signs are very important. When our patients are coming to the ART centers, we do not treat cancer, but what we can do is we create awareness, and I have to identify, and we have to tell our patients also, if you have any of these symptoms, come to us. Change in the bowel or the bladder habits, wound that does not heal, unusual bleeding or discharge, thickening or lump in the breast or elsewhere, indigestion or difficulty swallowing, obvious change in a wart or mole, nagging cough or hoarseness of voice. These are the things that they should report as unusual symptoms. And then we will go for the examination and the referrals. Now, cervical cancer screening, we do know that we do a pap smear with acetic acid, and that is the stain we do. And usually what we have is a normal squamous epithelium of the cervix. It appears pink. Columnar epithelium appears of the uterus appears red. But in conditions like inflammation and malignancy and suspected growths, we have this white, dense white patch of the cervical epithelium, and which is a sign which needs to be after the pap smear, we need to go for a biopsy. So whichever women that who comes with an abnormal discharge, or annually, ideally, these patients should be, any woman walking into an ART center should have the facility of a pap smear at least once a year. The risk factors for breast cancer, now again, at the same time, the risk factors is older age at pregnancy, early menarche, late menopause, never had children, and who take menopausal hormone therapy. Now the estrogen and the progesterone medications. The risk factors is, as we know that breast cancer has a BRCA1 and the BRCA2, that is the genetic factors that is hereditary factors. Apart from that, physical inactivity, alcohol intake, obesity, being obese or after menopause, these are also risk factors for breast cancer. Now, awareness, a woman should be told to self-examine her breast. If needed, it can be done by the nursing staff or by the physician. What should be the signs we will look into as the earliest sign? Change in the size of the breast, nipple that is either pulled in or retracted, or change in position or shape, rash on or around the nipple, discharge from one or both the nipples, puckering or dimpling of the skin, lump or thickening in the breast, constant pain in the breast or armpit. Screening, all women should be screened above 30 years of age. Examination to be done by trained physician or a nurse, or self-examination has to be promoted. Now breast, as I said, any change in symmetry in breast shape, skin changes, dimpling, retraction, ulceration, levels of the nipple, retraction, inverted nipple. Any discharge, color of the discharge, swelling lump, and swelling in the armpit, that is the axillary area, that is when you have a lymph node invasion, and the collarbone, supraclavicular area, and the root of the neck. After this, we usually send the patient for a biopsy and a referral to the oncology department. Now, oral cancer, this is very important because tobacco chewing is still quite common in our country. And this is a single most risk factor for oral cancer. Betel nut chewing, chronic trauma to the oral mucosa by sharp tooth or ill-fitting dentures. These are very common factors. Cessation of tobacco use should be the health promotion. We will advise. At ART initiation, any ulcer in the mouth which is not healing, any white patch or submucous fibrosis, that is the patient is unable to open his mouth properly, leukoplakia, erythroplakia, palatal changes, submucous fibrosis. These are basically the precancerous things that we have to look into whenever a patient is coming to my clinic. Visual examination is very important. A white patch, a big ulcer, a red patch, palatal changes, and then submucous fibrosis, that is the lips and the mouth is very close together. They are not opening properly. These are all observations that need to be done to screen for oral cancers. Now we have to refer the patient to a surgeon or an ENT specialist for further management. I come to the end of my topic with this. Thank you all for patient listening. If any questions.
Thank you so much, ma'am. Any questions from the participants? Please feel free to unmute. You can also type the questions in the chat box. Oh, ma'am, I don't think there are any questions. Can I go ahead with the feedback poll, ma'am?
Sure, sure.
Requesting all the participants, okay. Requesting all the participants to please attempt the feedback poll. Please answer all the 4 questions. Requesting all the participants to please click on the feedback poll. Thank you so much, ma'am, for facilitating this session.
Thank you. Anyone can contact me. They have my phone numbers if they have any queries later on. No issues.
Thank you, ma'am.
Okay.
Thank you to all the participants for patient listening. We'll end the session now.
Thank you, Zveta.
Thank you.